You can kind of make out that he's got this sort of to and fro sort of breathing. He's breathing with abdominal effort. Kind of see that he's a little bit restricted. Sorry about the video. It looked a lot better on my laptop. Now it's a little bit better. You can see he's really laboring. He doesn't look that stressed out, but he is. Okay, we can stop that one. Don't close it up. Okay, F5. All right. So with these patients, obviously it's important that we try to gain a quick assessment of what's going on. So a focused physical exam is going to be really important. You're going to assess posture. You can gain a lot of information by just looking at the cat from a distance rather than rushing in and putting hands on them. Mental attitude, breathing patterns, really important. Will help you determine where the problem might be. So looking at that kitty, start thinking in your heads. He's got this paradoxic motion of respiration. He has somewhat of a restrictive pattern. We can listen to his chest. You might hear some things that help key you in further. You can listen to his cervical region. Sometimes that'll help. And of course the rest of mucous membrane color, pulses, etc. So in this sense, hopefully you all came to the conclusion that this kitty likely has pleural space disease. So clinical signs will be this classic short, shallow respiratory pattern. Tachypnea, which that kitty appeared to be tachypnic, may have open mouth breathing, may be cyanotic, may have this paradoxic respiratory pattern. You saw that with the abdominal effort, or as he was breathing in, things seemed to poke out that weren't supposed to poke out. Dull lung sounds, percussion's kind of a lost art. Not many people percuss chests anymore, but it may be helpful. You may hear a muffled heartbeat. You may hear the presence of gut sounds. That's usually a big clue that something's not quite right if you're listening to their heart and you hear guts. And if you're really astute, you might hear a fluid line. So that's also helpful. So this paradoxic breathing, this came out in JAVMA, and looking at cats and dogs with pleural space disease, and they found that it's strongly associated with pleural space disease. So when you see it, you should kind of almost automatically zoom in to pleural space as being the cause of the problem. Those with paradoxic breathing, the prevalence in dyspneic dogs was about 27%. Cats had it much more often. And then for those statistical nerds out there, the positive and negative predictive values of paradoxic breathing were as shown. So bottom line is, it's strongly associated with pleural space disease. So that's a big tip. Differential list for these patients with pleural space disease includes pneumothorax, heart disease, diaphragmatic hernia, that's the gut sounds, hemothorax, chylothorax, pyothorax, and FIP. So pleural space, just a little bit of a reminder. We've got a serous membrane on both the visceral and the parietal pleura. The parietal pleura has a rich lymphatic system. And then we have the mediastinum, which is that area in between the right and left pleural sacs. And normally there's a small amount of fluid, and some poor resident had to figure that out, that there's less than 5 mils per 10 kilogram of animal. So there you go. But then when we get an abundance of fluid in the pleural space, then we're going to result in a loss of net negative pressure, collapsing of the lungs, and that production and absorption of that pleural fluid is controlled by Starling's forces. And we're not going to go into that in depth, other than say it's sort of the balance between hydrostatic pressure and oncotic pressure. There's a lot of other things that go into it. They're all very boring. So initial stabilization, oxygen, oxygen, oxygen. We're going to show, I'll have a few slides here. They'll show some how we can give oxygen to our patients. But the idea is that you're trying to give them supplemental oxygen to saturate maximally their hemoglobin molecules. As we talked about earlier, a limited physical exam is going to be important. So very careful, particularly cats are easily stressed. If you go in too fast and too hard, you're going to stress them out. If you rush them off to radiology, a lot of them die in radiology. So careful, focused, be patient with them, try to not stress them out as much, because collapse and arrest is very possible in some of these patients. So here's one way, sort of flow by or a mask sort of method. Nasal cannulas sometimes work in some patients. Oxygen cage, this big, huge one we had at CSU was sort of handmade by Schneider for us, but we had a lot of them. You can see one on top and a couple others. They're very helpful, particularly in cats that are trying to commit suicide on you while they're breathing, to the point of collapse. Pop them in oxygen, let them chill out for a while. That helps out, I think, a lot. No, seriously. There we go. And then the old oxygen hood. These have kind of fallen out of favor. I'm sure some people use them, but they tend to overheat, particularly if it's a dog and they're panting a lot. They tend to overheat. So just be careful. If you're using these, just be careful. I know that there's commercially available ones. This was before that time. I know Jorvet makes some commercially available ones. So stabilization. As with any critically ill patient, IV catheter is going to be an important part of what we need. They may need mild sedation, so here's a couple of drug doses that I tend to use. I'm a big fan of hydromorphone and midazolam. Doesn't burn, small, low dose. It chills out these cats sometimes very nicely. Has minimal effects on the cardiovascular system, but remember these patients have respiratory distress, and so whereas in other patients we don't worry about the effects of morphines on the respiratory system, in these patients you will, so you want to do low dose. So you might start out this low end of the dose of the 0.05. Midazolam doesn't burn, unlike diazepam, so it's helpful in that sense that you can get an injection in without causing further distress. Minimum database, you can get at least these two things right off the hub of your catheter, and then of course chest x-rays are important. Plus or minus ultrasound. I'm sure a lot of you have ultrasounds in your hospitals, and this is another useful place for that. If your radiographs are not that helpful, or maybe you can't really tell, is that fluid? I'm not sure. Then ultrasound may be a way of helping you out. So pleural space disease, the initial management, oxygen supplementation, thoracocentesis, typically before we get radiographs. Again, if you're looking at all the clinical signs, and you should be able to pick up pretty quickly that maybe this cat or dog has pleural space disease. And so looking at thoracocentesis as a diagnostic and a therapeutic means, I think, is very helpful. Most often they don't require sedation, but if they required it to get the catheter in, then you've got a little extra help there. And then you can collect that fluid for cytology and diagnostics. And now we'll try it again. No. Okay. We'll just go on. We'll just go back to F5. I'll just go on. Or just the little screeny thing. Okay. It's coming. It'll take a sec. There it is. And open. Open, open, open. Open. And, okay. You move it over just a touch. There we go. Okay. And have to play once we let go. Okay, so this is the same kitty doing thoracocentesis. We clipped a little area, a little square out of the middle of his chest. I'll show you the setup in just a second, but it's a real simple little setup with needle, extension set, 3-way stopcock, and a syringe. Cat is minimally sedated, if any. Inserting in between rib spaces, roughly 4th or 5th intercostal space, and there's our fluid. Doesn't look so happy. It's hard to judge based on its appearance here, but we'll know a little bit more in a second. Now we've got your sample. You can do diagnostics here, and this is going to greatly help out this kitty breathe. You may not get all of it out, and we'll see why in a second, hopefully. But at least now you got your sample, and there's your sample. No work? No work? Okay. Okay. Okay, so there's a setup for thoracocentesis. Real simple. You can have these made up, ready to go, put in a little plastic baggie, have them near your crash area, your crash cart. And I know some folks favor catheters. Sometimes I'll use one. I always go back to the needle, though. It seems to work the best. The catheters collapse, and the cats move, and the dogs move, and the catheter gets kinked, and you get frustrated. So I usually just use a needle. So in some cases, we have to consider placing a chest tube. And in this cat, we're heading down the route. I'll give you a little foreshadowing. This looks like a pyothorax. So chest tube is going to be important. But the decision to place a chest tube may be reached in other ways. So if you can't reach negative pressure, let's say it's a pneumothorax, and you perform your thoracocentesis, and you're pulling, and you're pulling, and you're pulling, and it's like, well, this is a 5-pound cat dog, and it's just not getting negative, probably time to put a chest tube in. Or if you can't evacuate the chest completely, perhaps in this case. We got a lot of fluid in there, so you may not be able to get all that fluid out of there. Or if it requires repeat thoracocentesis, and there's this so-called 2 strikes rule. We'll try the video. This is the last one. And, yep, and there we go. Okay, so now our kitty is anesthetized. We're only going to put 1 chest tube in. He's being blocked here with some lidocaine marcaine. This first block is right around the 9th intercostal space or so. Make a little stab incision. Make a little tunnel. Got a trocar pointed chest tube, trying to get an idea of how deep that should be, so you're kind of placing it towards the cranioventral aspect of the chest. That little squeeze that he did there helps out a lot with cats because they have a very compliant chest. So if you can squeeze their chest and kind of bow it up a little bit, that helps out a lot. Chest tube's in. Don't pull the cannula out until you have all your stuff ready. You should have all this other stuff here connected and ready to go. So you got your catheter adapter, 3-way stopcock, extension set, maybe even connected to another 3-way stopcock and your syringe. All that should be ready to go so that once you pull that trocar out, you can just zap it all together. And there's the stuff. Lots and lots of stuff. Now we're going to suture it in. These 2 little sutures here that's being placed around the chest tube, underneath the skin. Make sure you don't skewer the chest tube. That would be a bad thing. You have to replace it. But just making sure you kind of clamp down that tunnel so that you make a good seal. And then around it, a little finger trap. Finger trap the tube. Done. Okay, last video. When it's highlighted. Or that. There you go. Okay, thank you. So, pyothorax. Not a super common disease, but we see it sort of different times of the year, kind of depending on where you live. We saw them back east a lot in the spring and the fall. Seems like that's when the cats are out running around and doing their thing. But they have these sort of vague histories of weight loss, decreased activity, lethargy. I mean, that fits everything. There may or may not be any respiratory changes. There may not be any of that history there. But then on physical exam, maybe they have muffled heart sounds. Maybe they have lung sounds that are muffled. Maybe you then do your radiographs, ultrasound, etc., and maybe even jump straight to a thoracocentesis because the patient's history and physical exam findings fit that. Ultrasound, again, as I mentioned, is helpful in some of these cases. You're going to need fluid analysis to determine the nature of the fluid because, unless you're very astute and can tell maybe off the hand, or maybe it smells really bad like a sewer, then you have FIP, chylothorax, and other effusions that you're going to have to be ruled out. And the reason that may be sometimes difficult is maybe he's had previous antibiotic use. Maybe you've seen him a couple days ago and he wasn't quite feeling well and he got antibiotics. And then he's come back a few days later and now he's got pleural effusion, but you may not have the same sort of cell type within that fluid at that point. Treatment, typically most cats are going to need unilateral chest tubes. Bilateral may be needed if you're not getting complete drainage, or if there is other problem that may be coming up about maybe the tube goes bunk or something like that. But at least with a unilateral tube, then you can start the pleural lavage that may be needed, or at least keeping that chest tube evacuated. Your antibiotic selection is going to be the so-called 4 quadrants, so aerobes, anaerobes, gram-positive, gram-negatives. And there's just a couple of examples. This is probably the most common set to start with that I would use. enrofloxacin for the gram-negatives, and maybe Unison or Tycar, clavulinate for the gram-positives and anaerobes. But ultimately, you're going to rely on your culture and sensitivity to help guide you, because you're going to go from mallet to ball-peen hammer as far as your selection of antibiotics. Oops, too much. Other treatment, is that right? Yeah. Treatment, oxygen, IV fluids. Daily cytology is really helpful for these patients. So once you've got the chest tubes in and you're maybe lavaging and you're evacuating that chest on a regular basis, maybe every 4 to 6 hours, depending on your availability, checking that cytology on a daily basis will help you determine, am I doing what needs to be done? Am I seeing fewer and fewer active, reactive sorts of neutrophils? Are the bacteria that were present extracellular? Now they're all intracellular. Now they're gone. So it allows you kind of make that progression and make sure that you're kind of staying in touch with what's going on in that pet's chest. So it's a helpful thing to do. We do it in other instances as well, just as an aside, like for peritonitis cases where they have drainage systems in. Daily cytologies are helpful for these patients. The decision for thoracotomy is generally based on a number of factors, but one of them might be the so-called failure to improve over a couple of days' time. So if that patient has a good chest tube in, you're getting drainage, you're thinking everything is going well, then it's not going well and things are not getting better, then you might start thinking about doing a thoracotomy. Another decision point may be that after you got that chest evacuated, if you see evidence of mass or abscess or suspected abscessation, I should say, then maybe that's a time to consider thoracotomy. Thoracoscopy is also an option, not something that we generally just jump right into, but there may be some cases where it may be useful as a diagnostic is to consider thoracoscopy. It provides you with excellent viewing of the intrathoracic structures. You can get a biopsy if needed, if it's more mass suspicion. It's minimally invasive, and it could be an alternative. Or it could be something that says, well, we're going to explore it with a thoracoscopy method and then convert them to a thoracotomy. So that may be something to think about as well. So the bacteria that are present in these patients, and this is a study that came out of JAVMA as well, or published in JAVMA in 2000, where they looked at a wide variety of cats and dogs with pyothorax. And it's a mixed bag, as you can see. We've got obligate anaerobes and aerobes. And it was interesting to point out that the dogs mostly end up with these enterics, whereas cats end up with non-enterics, mostly Pasteurella. And actinomyces tend to be a fairly small percentage of the patients that were evaluated. So the difference between dogs and cats is enormous, but overall, cats and dogs, pyothorax has a fairly guarded prognosis. A study by Rooney et al. Looked at dogs treated for pyothorax, and their study seemed to lead us in the direction of saying that dogs do better with surgery. At least in their study, they felt like it was 5.5 times more likely to fail if they did medical therapy only with these dogs. And there's other newer studies that don't seem to support that, and we'll talk about that in a second. Waddell et al. Did a study in cats that looked at overall survival and factors that fit into these cats with pyothorax. And they found 66% of their 80 cats survived, and only 5 of those required thoracotomy. So seeming to kind of go along with maybe some of the data on the dogs, so to speak, that Rooney found. An interesting point on the cats was this low heart rate and hypersalivation tended to be a poor prognosis. Their explanation for the hypersalivation may be more of a parasympathetic override, or maybe some sympathetic system that just shot because of the shock situation, the septic situation. And then we all know that cats with low heart rates oftentimes are shocky. Dogs, this is a more recent study from JAVMA in 2010. Booth et al. Looked at 3 groups of patients. So group 1 was so-called non-invasive, treated with just thoracocentesis and antibiotics, and they had a 29% short or long-term survival rate. So probably the least advised route. The invasive group had thoracostomy tubes only, with or without lavage, with or without heparin, and they found that they had, in these dogs, 77 short-term survival, 71% long-term survival. So close to Rooney's figures. And then the last group was thoracotomy with thoracotomy, chest tube, and lavage. 92% short-term survival, but only 71% long-term survival. So similar to their thoracostomy tubes only. So their final conclusion regarding surgery in these, at least in dogs, was that surgery didn't seem to affect short-term survival with surgery. So it's still a matter of probably clinicians' intuition and what they think is going on with the patient. They were also a group that used heparin in their lavage. I don't think the word's out on this. I think it's mostly a sort of clinic-to-clinic preference. But they put heparin in, and they felt that it had some benefits to their survival. But as I mentioned, they failed to prove that invasive versus non-invasive treatment led to a better long-term outcome in their dog patients. Any questions? Yes, sir.
Does the actinomyces that you culture come from plant material, like foxtails?
So the question was, is the actinomyces that's found in some of these dog chests predominantly, is it thought to come from plant material, and that's a leading thought? It's not certainly a known obligate and bacteria of any part of the dog-cat body, so it's probably as an external sort of bacteria.
So would that dictate a higher chance of going to surgery? You culture that out of your dog's chest?
Well, but then going back to the Rooney study where they seem to favor surgery for dogs in the first place, I don't know if there's any particular study that took that subgroup out, because there was actually fairly few dogs in that Rooney study that had actinomyces, so they could pull it out and say, as a subgroup, which of these went to surgery.
So in cases that you guys cut, you frequently find foxtails in the chest?
The ones that I've had, and Diane could probably comment more on these, oftentimes you can't find the material. You find this, if they go in, they debride the chest cavity out, they just find all this junk and this necrotic tissue. And on a rare occasion, you might kind of slice through that stuff and you might find what you think is some plant material. It always shows up in the pathology case of the month in JAVMA. Any other questions?
What's your frequency of lavage and what volume?
So the question is frequency of lavage and volume. It's about 20 mils per kilo, approximately, and every 4 to 6 hours, typically, depending on, some of it may be clinic factors that go into that as well, but 4 to 6 hours. And then there's some folks will let it dwell in there, but I usually don't let it dwell into the chest. It's usually just a matter of just the physical lavaging of getting that fluid in there, kind of turn them from side to side, slosh them around a bit, and try to pull it all off, but you're not going to get all the fluid off. So don't be surprised if that happens. And that may be another indicator for a second tube. I'll let Diane comment more, but I think my experience has been that we usually make the decision sooner to take them to surgery. And in some cases, it's much sooner. It's not even allowing them to have sort of a couple of days with the tube. It's still very sort of patient-driven sort of decision. But if it's already spent some days at another hospital and comes to you and it's still not getting any better, that's probably the time they'll pull the trigger to go to surgery.
Is this one live? Yeah. I would say that the majority of the ones that have the actinomyces that we cut, we chase down the tracts, but not a lot of them. There's a small subpopulation that are actual intrathoracic that have inhaled a foxtail, but the majority of the ones that go to surgery are the ones that we're chasing them down in the thoracic wall, in the abdominal wall, and in the soft tissues more than in the actual pulmonary tree. And yes, adhesions and disease and sometimes just resecting the entire lobe that's been damaged can result in a cure, and you never do find the actual foxtail.
Is there another question over here? Anybody? Okay, thank you.
Is this one on?
Is this on? Yeah, we're good. So today I was going to talk about acute on chronic cough, and we sort of decided to collaborate between surgery, critical care, and internal medicine. I wanted to talk about cough from the perspective of when we see these cases that come to see us for coughing. A lot of times you may have a dog that goes along for a while with a cough and then suddenly decompensates. And the question is, what is playing a role in that? So I didn't want to get too much into the pathophysiology. We all know that coughing. Okay, going forward. So again, the chronic airway diseases in dogs and cats, they can decompensate pretty quickly when you have a chronic cough that suddenly becomes complicated with another disorder within the airway system itself. A cough is not a sign, is a sign of an underlying disorder, but not a disease itself. And a lot of patients that come in with a cough have a combination of factors, and I think it's important to look at the patient individually from the perspective of history, breed, all the factors involved to try to sort of narrow down where our cough is originating from. Chronic cough is considered chronic if it persists for 2 months or longer. Again, taking into consideration historical information, travel history, description of the cough can help you to pinpoint the etiology. Sometimes having an owner come in, I'm sure you're aware, cats and dogs alike, trying to get to the bottom of, is that a reverse sneeze? Is that a cough? Is that what's going on here? Sometimes really trying to listen to what they're saying, and because they obviously won't want to cough on command most times. But some owners will also bring a video, which certainly helps a lot of times when we're trying to determine where we go with these patients. I wanted to really sort of stress on the fact that a lot of times with coughs, there's a lot of different things going on. Obviously, some of the more common things that we see, and I'm sort of taking things more from a dog perspective than a cat. Chronic bronchitis being a really common cause for a chronic cough in dogs, whether that's allergic or irritant in nature, which leads to COPD. Brachycephalic syndrome, when it's combined with chronic bronchitis, or collapsing trachea is a common issue that we see when they decompensate pretty quickly. But keeping in mind there's other extra airway diseases, I think, that play a big role in a dog coughing that I think we aren't always honing in on, and it's not until we sort of look at everything from the nasal cavity all the way down to the lower airways, then putting it all together with the cytology from BALs and that sort of thing to try to determine, well, where do we go from here and how do we help this patient individually. Again, problems associated with cough going from the nasal cavity, cardiac disease, and lower airway, upper airway, how do they play a role together, alone, and even sometimes considering things like GI disease. Some patients, I do think, have a bit of gastric reflux that come in and they're having this cough. And again, I think it's important then when we're going to diagnostics, again, looking at all the different areas that could be contributing to a cough, maybe not just the airways alone. Diagnostics initially, we're looking at all the different areas, the oral cavity, nasopharyngeal region, the bronchi, trachea, and again, thinking about other areas that may be contributing to the cough. So blood work, obviously a minimum database. From your history, travel history of fungal serology is going to be important, and heartworm testing. Radiographs, obviously, to look at not only the lower airways, the trachea, but even cervical and nasal regions as well. Advanced diagnostics, obviously, including the laryngeal exam sedated, so we can get an idea, is there something going on in the tonsillar regions, what's going on in the laryngeal region and how that's contributing. Looking at ultrasound, endoscopy to look at both the trachea, lower airways, and looking in the nasal region as well. And CT scan and fluoroscopy also plays a big role as well. Advanced diagnostic, I wanted to sort of point out, a lot of times patients come in with a chronic cough and, financial restraints may limit them from doing some of these advanced diagnostics, whether that be a bronchoscopy, CT, and whatnot. A lot of times early on, it may be suggestive of, if they're having a chronic cough, the likelihood is this is chronic bronchitis. Can we try empiric therapy with inhalers, antibiotics, and see where it goes? But I like to stress to people, especially in these patients that have a chronic cough or acute on chronic exacerbation of a cough, it's important to really evaluate all these areas because it may give us a perspective of what's really going on in the lower airways, and that may give us an idea of prognosis for these patients. So, for example, if we're seeing a collapsing trachea, how bad is that? Is a stent needed at this point because we've exhausted medical management? If we look in the lower airways, is there a significant amount of lower airway collapse? And that may help us to tell an owner, hey, there is quite advanced disease, and we may benefit with the therapies, including inhalers and whatnot, but we may not improve the cough more than 70%, and that may be as best we're going to do. And obviously for obtaining samples like bronchial brushings, BALs, and biopsy if needed. So I wanted to point out a couple cases that I collaborated with, both surgery and emergency. Zelda, she was a 13-year-old dachshund who had multiple internal medicine problems, so I couldn't really list them all on one page, nor her medications. But she had been diagnosed with polyarthritis, hepatopathy. A mucocele was removed about a year and a half prior to her presentation, and she had a new problem, which was an acute cough. It had never been apparent before. Also decreased appetite with occasional sneezing and an increased respiratory rate. On physical exam, it wasn't that remarkable aside from a small cough that could be elicited. Her blood work, obviously some mildly elevated liver enzymes. On X-ray, her heart was a little bit generous, and there was a scant amount of pleural effusion, which prompted us to look at an echocardiogram and a consolidated left lung lobe with a possible mass effect. It was interesting to look at the X-rays of her chest because there was this area of consolidation in the left cranial lung lobe, which is unique because thinking about what this could be, was it a mass effect? Was it aspiration? If it was aspiration, it's a pretty unique area for an aspiration to occur. So going on to a CT scan. Hang on. We found a diffuse interstitial infiltrate throughout the left cranial lung lobe that seemed most consistent with some sort of aspiration. The next step was to go to a bronchoscopy, but this is where I think it's interesting to put all these pieces together. There really wasn't a whole lot of airway disease going on that could account for the cough, which prompted us to look then into the nasal cavity in the nasopharyngeal region. We found a focal turbinate area of necrosis. Was it a possible mass effect within the right caudal nasal sinus? Upon biopsying that, it was found that she had some chronic lymphocytic rhinitis. We cultured out strep bovis, and her BAL cytology was consistent with a moderate neutrophilic infiltration, consistent with an aspiration. So just coming to the diagnosis, it was an aspiration pneumonia. She had a chronic rhinitis, and we suspect that some of these patients, again, we're not dealing with a primary airway disease, but we have a chronic rhinitis, and they have possibly this postnasal drip, and I think there are a good percentage of these dogs that aspirate on these, and that may be then contributing to the cough. So that's the first case. Outcome with her, she had a 3-week course of antibiotics combination. Her cough improved. Long-term management included rhinocort nebulization with antihistamines, and she did really well. An occasional cough here and there, but repeat radiographs showed resolution of the aspiration pneumonia. Fluffy was a 9-year-old poodle mix that presented for an acute on chronic cough. This is, I think, a really interesting case. Fluffy had, she had been treated presumptively for collapsing trachea for a few years. So when she presented to me, her history was that she had this chronic cough that suddenly just worsened in terms of frequency and intensity. Referring veterinarian's radiographs showed a primary or a solitary pulmonary mass in the caudal lung field. So that was really what her primary presentation was for the pulmonary mass. But talking to the owners, the question is, if we have this primary pulmonary mass, is that the entire reason for this dog's cough? Knowing the dog's history, which again I think is important to talk to these people about the chronicity of the cough, why it's worsened. Are there other things going on, vomiting, sneezing, to help us to try to isolate what our next step is? Because if we decided to just send Fluffy off to CT and surgery, my feeling would be I wouldn't completely get rid of this dog's cough. So again, a caudal lung mass. But so we sent her to a CT scan, which confirmed this single mass, no metastatic lesions, and the next step was to look in the airways. She had a mildly elongated soft palate with a grade 2 out of 3 collapsing trachea. And on bronchoscopy, what you could see was obviously confirming the tracheal collapse. As we got down to the bifurcation of the bronchi, this extraluminal mass sort of extending into that lower airway. So she was probably having, well medically managed for her tracheal collapse, but this mass on top of her tracheal collapse really caused her to decompensate pretty quickly.
This is a demonstration of Flipformat.
Yeah. You don't have to buy it, by the way. Just download it. Kudos to Ethan. So Fluffy went off for a thoracotomy, had a surgical resection of the lung lobe, of the accessory lung lobe, and the biopsy results were consistent with a bronchoalveolar adenocarcinoma grade 2. I'm like, look at David over there, lying that out. But after removing the tumor, the cough improved dramatically, not completely. Long-term management included diphenoxylate for the chronic cough and Flovent and albuterol inhalers. And Fluffy is doing well. I think one thing I just wanted to sort of interject, I may have said it before, but I like to tell people, especially when you're dealing with tracheal collapse or even chronic bronchitis cases, if we can get these patients medically managed and maybe 75 to 80% better, then we're really doing our job. But then if they come back to us, suddenly they're decompensating, what are the things we have to think about? Are there other problems or issues that have occurred now, whether that be outside of the airways, the upper airways, whether that's laryngeal paralysis, nasal disease, that have suddenly caused them to decompensate? Or is it something more common, whether they aspirated or we have some sort of infectious process on top of things? So I think those are the main issues I sort of wanted to talk about here. Nikki was another patient that we collaborated with surgery. Nikki presented, she had abnormal breathing for about 6 weeks, orthopnea, and exercise intolerance. On physical exam, she had a grade 3 systolic murmur with some inspiratory stridor and nasal stertor. Minimal database showed a normal heart size with some mild atrial enlargement. Echocardiogram compensated mitral insufficiency, but no evidence of pulmonary hypertension. Bronchoscopy showed an elongated soft palate with a grade 2 collapsing trachea. And on retroflex view, a choanal mass was found. I think it's maybe the video. Oh, okay. Sort of there was some pictures that maybe they didn't show up. I don't know. Maybe I had some pictures of the choanal mass and the bronchoscopy that maybe didn't convert over. No? No. Okay. So Nikki went on to have soft palate laser surgery. In addition to that, the nasal mass was resected with follow-up palliative radiation for the nasal carcinoma, and she's doing well at this point. Any questions?
I'll use this one. This one's on. Hi, guys. We put this panel together because respiratory disease is not often a single disease. It has an emergency component, it has a medicine component, and then surgery gets involved. I put together some pictures, and hopefully the pictures won't be too gory. I have some video that sounds like Cujo that's pretty loud, so, and if we can get the videos to run, that would be awesome. So surgery of the upper airway is what I'm going to talk about today. The upper airway includes the nasal cavity, the nose, the nares, anything you can see on the outside, and the upper airway, which is anything you can hear when the dogs are breathing. So clinical evaluation for us, when we see these patients, usually the complaint is something's wrong with my dog. My history is that he doesn't catch the ball anymore. He won't have repeated attempts at retrieval. He gives up. He's exercise intolerant. Sometimes we'll see that they have inspiratory stridor. You can hear them coming. The respiratory effort tells us a lot about whether it's upper or lower airway. I'm going to apologize right now that I talk fast, and I have probably 5 cases to run through. So if anybody wants to ask questions, you're going to have to slow me down. Exercise tolerance is a big thing, especially for the sporting breeds. For us, we like to rule out lower airway disease and send them to Kerrie for lower airway disease management. A lot of the patients that we get are referred from the emergency clinic because they've had weekend excursion and they've had collapse, or they've had what their owners believe is some sort of airway crisis. For us, the laryngeal examination is what tells us what's going on internally. Physically, you can see what goes on externally. Laryngoscopic exam is good for the dolichocephalic breeds, the dogs that have really long face. Otoscope works pretty well for cats. Laryngoscope also works well, but the problem with airway evaluation is it can be that as you evaluate, you become part of the airway. You distort the larynx, you distort the epiglottis, and you don't really see what's happening like they do in horses that can be put on a treadmill, and you can put in a scope and just watch everything happen. We have the disadvantage in small animals that we have to anesthetize them, so we're already intervening, and then we have to, in addition, distort things in order to get an idea of what's going on. The flexible endoscope works the best for us for recording, so hopefully some of these videos will run. The first part of the evaluation is clinically, we look at the animals, how are they doing, what does the owner think about their overall health, do they have lower airway or upper airway, before we ever try and do an airway evaluation, because an airway evaluation for us requires general anesthesia. We have to knock them out, they have to be stable enough to be knocked out, and we have to make some choices about, are we diagnosing only, are we going to diagnose followed by surgery so that we don't have to recuperate a debilitated animal with a crippled airway, are we going to stage this, or are we going to try and do it all at once, including the surgical solution? So for us, we like them to have a mild pre-anesthetic, something that just takes off the edge some type of anti-anxiety, maybe a butorphanol, something to keep them from coughing. For us, we use propofol induction, and we stand by with the endotracheal tube in case they get into trouble. For us, when we're looking at specifically laryngeal function, can be really difficult. As soon as you get them anesthetized and you get nice in position and everything's happy and you get in there to look, nothing happens because they're apneic. So I do get a lot of phone calls that tell me that I think he has laryngeal paralysis, but I'm not sure because we anesthetized him, we looked, and nothing was moving. Is nothing moving because nothing's moving, or is nothing moving because he is sedated or anesthetized? So the best look that you get at an airway is either when they're first going down or when they're first waking up at the end of the anesthetic episode. For us, we use a drug called Dopram and give it intravenously, which is an artificial stimulant for dogs to move their arytenoids if they can. It gives us a forced look, but it's better than an apneic look. This is a typical endoscopy picture that we look at, and does anybody in the back have a pointer they can use to point at stuff? Because we can't, like an assistant to point, because I don't think I can. TJ has one. I saw him flashing it earlier. Can I get somebody that knows something about airways? Not the dermatologist. No. How about the other surgeon? Oh, there we go. There we go, medicine. So for me, the nasopharynx, in this view, we're already long past the nasopharynx, but the nasopharynx is a place where we see foreign bodies and foreign body retrieval, not so interesting for us. Hard palate, we do see some diseases that cause hard palate disruption and genetic diseases like palate, cleft palate, partial cleft palates. Soft palate for us is very interesting. In this view, we're going to look at the tonsils. Where are you, Cindy? Tonsils, arytenoids, and the epiglottis. That's the quadrant, the triangle that we look at, the right and left arytenoid, and the epiglottis. So in my laryngeal exam, it would be nice if they were all still like that, but they're not. They look like this. So this is a loop. It's going to repeat, which they never do. So this dog has got good laryngeal function. He's moving his airway in two directions. He can open it, and he can close it. This loop repeats over and over again. So the arytenoids that I'm looking for, functionally, I need to know, is my arytenoid, which is a dorsal portion, is that clear? Is it moving? Is there a mass anywhere in there? Does the soft palate participate at all in obstructing the larynx? Does the epiglottis get involved? And the view that we have here, we're really close. Like you've crawled all the way into his airway and you're sitting on his epiglottis, trying to look down into the lower airway where we sometimes can make a good evaluation about lateral ventricles. So this dog is what we would consider normal. And we don't get a view of this for very long because as soon as they're normal enough to move their airway, they wake up. Planning for us is everything. A lot of these cases, I'm sure Mike can tell you, are critical, and just the manipulation, like he was talking about cats. Dogs with airway obstruction are in distress, their owners are in distress, and they can be fragile patients. I hear a lot of owners that say, well, my dog's a bulldog, and so he's special, and he can't have anesthesia, and he can't have, and they give you a list of things that he can't do. But what he really can't do is compensate for any kind of stress. He can't have heat stress, he can't have anxiety, he can't have environmental stress. And for these guys, the clinical signs and the planning for us is everything. If we have a dog that's stable, we don't bring out the bells and whistles in order to do an airway evaluation, but if we have a dog like this, I always inform the owners that this dog is likely in crisis. He's barely hanging on to the air that he's moving, and that when we anesthetize him, we're going to compromise his airflow, so we're going to have to protect his airway, and there might be some choices to be made about solving his problem. Does he need a palate resection before he wakes up? Are we going to wake him up in the ICU? Are we going to put a suture in his soft palate, exit the suture out the front of his oral cavity, and hold on to that suture until the last moment and when we extubate him, and then allow some tension on that soft palate so that he can use his larynx until he's wide awake. And then we just pull the suture out so that he can go back to his same crippled breathing. But you have to remember that as you evaluate him, you're compromising him pretty severely. So let's see if I... So for these guys, our planning is the pre-op. What are we sedating him? How are we keeping him comfortable? Are we taking him to surgery? And then how are we going to wake him up and make sure he doesn't have a respiratory crisis that puts us into, euthanasia? So here are my clinical cases. We'll start easy. This is a extremely obvious, easy one. We see a lot of exotic breeds that they breed for this, that, and the other, but they forget about the airway. So this is a Dog de Bordeaux, and correct me if I'm saying that wrong. It's an aggressive dog. It's used for protection. The dog has respiratory distress. He's a 7-month-old dog that probably weighs 180 pounds, and he is meant to be a breeding dog. So yes, our job is to counsel the owners that this is a heritable defect, and you might have one dog that has Mary's that's abnormal, or you might have a whole litter, but breeding him is asking for all of his wonderful traits, but it's also bringing about all of his stenotic Mary's traits. A closer look at his Mary's, if you look into the nose hole and all you see is tissue, he's not moving any air. So this dog has open mouth breathing at exercise, and his nose slits are slits, not holes. If you want to move a 180-pound dog, you need a hole, not a slit. So this dog came in because the owner recognized that several of the dogs that she'd bred had this small conformation, and she wanted to know how we could cosmetically do this so that he could continue to show. Not ethical. A lot of the breeds that we see that are exotic that have this, we also see it in cats that are exotic, and brachiocephalic is a classic for it. We also see it in Shih Tzus and some other toy breeds. So there's been a lot of controversy. You wouldn't think there would because it's a little nose, but there's a lot of controversy about what the best way to cosmetically and functionally improve this slit and make it into a hole. So the top diagram is an upside-down V, and that's the area that we're supposedly going to remove. But in a dog that has a tiny little hole, it's impossible to get your 11-blade scalpel in there and make an accurate assessment. So the diagram here is about half the size of what I would resect. I would resect a triangle much larger. So that's called a wedge resection, and it can be done with a scalpel or with a laser. I have not used a laser but once or twice and have not been happy with the kind of scarring that I've seen, so I don't use a laser on stenotic Marys in these dogs. Now recently it's been appreciated that not only is the outside hole too small, but it looks like that whole scroll is taking up way too much room in the nasal vestibule. It's way too big, way too wide. So how do you take a little wedge? Wouldn't it really be better to just take a cylinder? Why not just drill that whole thing out and remove it? So for me, I do the same type of surgery as is in that diagram, but I don't do a little wedge. I do a long, skinny, cylindrical wedge, and that removes enough of that actual nasal concha that they have an open vestibule, and it also allows a little strip of mucosa so that you can suture it back and give him mucosal closure. I think mucosal closure is important in a big dog just because depigmentation, scarring, strictures, and also it looks better cosmetically. The other type of surgeries that have been advocated more recently, like using a 6-millimeter biopsy punch and just drill your hole with the biopsy punch until you have a round hole, a round cylinder, and you're blindly removing that tissue. So unfortunately, there's a lot of hemorrhage. I have not found that type of surgery to be too successful. For me, I control hemorrhage by putting Q-tips into the nasal cavity. And when they have a slit, you start out with one Q-tip, and as you resect the wedge, then you have to put another Q-tip and another Q-tip. And when you get to about 3 Q-tips, the hole's probably big enough that he can breathe. It allows compression. The Q-tip provides compression to the flap and allows you a chance to see what it is that you're suturing because it controls bleeding as well. Occasionally, we will use some hemostatic powder, or we will sometimes use gel foam, but most of the time, this has to be done quickly because the only hemostasis you have is pressure. So now he has round holes instead of slits. He has sutures. They advocate using, all the literature says use non-absorbable. I use absorbable suture that's colored. A lot of the times the dogs will have it slough off before they come back at 2 weeks to 3 weeks. When I look at these postoperatively, I like the nasoplanum to be symmetrical and flat. I like it to be cosmetic so that when they look at the dogs, you can't tell he's had surgery. I also like symmetry. If you take a big wedge on one side, take the same size wedge on the other, none of these dogs are ever symmetrical, so you have to make them symmetrical. The nasal vestibule is what you're most interested in, getting him some room in there so he can breathe. The alar fold is the fold on the very outside. Thank you, Cindy. The very fold on the outside that some people, especially in smaller dogs, you can just remove that whole vestibule. You just remove that whole fold, and they have a T instead of a normal nose shape. The biggest complaints I've had are depigmentation. There'll be a white spot where it granulates in. Scarring, we haven't really seen too much in the way of scarring, and I have had dogs have to come back because we hadn't taken enough, and they needed a bigger hole. So I would say being aggressive early is preventative for these guys for respiratory distress. Brachiocephalic cats, people laugh, and I heard him laugh just now. Brachiocephalic cats, we see them more and more, the short hair breeds, the small, petite face, the number of cat breeders that really search for cats that have this type of presentation. The second case is a 4-month-old Persian cat that's owned by your technician. She breeds them. She brings it in and says that she would like to continue showing and breeding these cats. And so same thing, ethics. You know, your advice is this is a heritable trait. When you look at this cat's nostril, it's almost ridiculous. This is a 4-month-old kitten that spends the majority of his time open mouth breathing because he can't really move enough air through his turbinates to make a difference. He presents with stridor, respiratory distress, and open mouth breathing, and sometimes these kittens, once they play a lot and get overheated, they end up at emergency clinics open mouth breathing. I'm not sure how well this shows up, but for a cat like this, there's not enough room to do a microscopic wedge resection. This cat probably would have been a good candidate for a biopsy punch. That technique wasn't really described when I did this cat several years ago. And so he had a lateral wedge. I removed the entire lateral margin of his alar fold and just basically gave him a nose hole that was appropriate but not very cosmetic. My kids, when they saw this slide, want to know what we were doing to torture the cat. Ta-da! No, bilateral. The question was unilateral, and the answer to that is I do see unilateral stenosis, and I sometimes see alar fold defects that are unilateral, but almost always the stenotic nares is bilateral. So in a cat like this, I might actually do a biopsy punch technique. That would be one I would attempt. Postoperatively, they're open mouth breathing. They have a lot of congestion. You can see this cat has a lot of conjunctivitis. Some of these cats are chronic herpes carriers, and famciclovir is a good choice to control their stress and their herpes while they're recovering. We treat them with intraoperative antibiotics. We follow up with antibiotics afterwards. And scarring for these guys is really cosmetically and functionally the biggest challenge that they have. Third case I'm going to talk about is back to the brachiocephalic dogs. This is a 4-year-old French bulldog that the owner complains is gagging, coughing, vomiting after he eats. They don't really feel he's exercise intolerant. They know that the breed makes a lot of noise, so that's okay with them. He's been making a lot of noise since they've owned him since he was a puppy, which is all 4 years. And the reason that they're seeing you is because he is snoring at night, and he can't keep up with the younger puppy that they got. And they're concerned that maybe now's the time. Now he's developed some airway problems that they were warned about when they got the breed. For a dog like this, preparation again, as I talked about before, we really make sure that we are prepared to support his airway. If we anesthetize him, want to have a peek and find out that he's a respiratory cripple, you need to have everything ready to go before you start giving him any kind of drug that's going to compromise his airway function. When we look in his airway, and Cindy will help me on this, his airway's small. It looks edematous to me. He looks like the roof of his soft palate has got a cobblestone-y appearance. I don't like the fact that his soft palate is sitting inside his epiglottis, all tucked in bed like that. It doesn't belong there. He obviously spent some time not breathing through his nose because he had stenotic nares. So he is breathing through his mouth, which allows the soft palate to fall into his airway. On the right-hand side is a diagram of kind of where we would like his soft palate to stop in the perfect world. But when you look at the airway diagram, you can see that both in the real time and also in the diagram, we have a big old steel retractor in there to try and move the redundant tissue away so we can have a look. When you do that, you pull the tongue forward, you put your laryngoscope in, and now you've brought his airway forward about 5 or 10 millimeters. So now his airway is way far forward of where it sits in real life when he's running around the backyard. And so now his soft palate does look too long because his airway is in his mouth because you've pulled it forward. So the tough part of these is all about positioning, the holder, and how he is positioned when you're doing the airway evaluation so that you're not forced to drag his tongue all the way out. So a neutral position is what we try and achieve when we're doing airway evaluations. For him, it was clear his soft palate's too long, so I know boarded surgeons across the country argue ad infinitum about whether the laser or the cut and suture technique is better. So I would say our strongest pitch is for positioning. I like a mouth gag. I like their upper canine teeth suspended from a rack so that they are stable and supported for the entire length of the procedure. Positioning is everything for us. Surgical resection, for me, I use a laser. I think the laser provides a nice sharp margin. It's very accurate. I put 2 sutures in the free margin of the soft palate, pull it forward, and hold it with my left hand while I put a tongue depressor below the palate to protect the airway, and then lay the palate on top of the tongue depressor and just cut across in the tonsil to tonsil like they have in the diagram. The diagram on the right there is an intubated dog that's having a soft palate resection with a cut and suture method, which some people love, but I think is just a little bit clumsy. The technique to determine where do we cut the palate so that it's the appropriate length. I know in horses they worry a lot about too short. In dogs we don't seem to worry too much about too short, but we do like it to be symmetrical and smooth. My preference is a laser resection. Postoperatively, they're so much more dramatically improved that it's easier to recover a dog that's had the palate surgery than one that has not. So for him, you get done, you cut his palate, everything's good, and then you look in his airway and you realize he has everted laryngeal saccules, which is probably one of the questions I get the most is how do you see that? Where is it? How do you know where it is? How can you recognize it? What's our landmark? Well, there really isn't. The shape and the size of the different airways, depending on how much distress the airway's in, it's always going to be ventral. It's always going to be in the sulcus, like up and over the mountain. As you drop into the airway, there will be shiny, glistening left and right balloons. Laser, for us, the laser doesn't... I didn't have as much success with a laser as with a biopsy punch or a guillotine method, so we use a Alice tissue forceps, put a long Metzenbaum in, and amputate them right at the lateral vocal fold. So now that the brachiocephalic syndrome has been prevented in all your patients, you have a dog that looks like this. He's had amputation of both of his lateral ventricles. He has a short, soft palate. You can see his airway. He has, if this were video, you see he'd have good movement. He doesn't have great movement, but he has good movement. And I'm going to say that the majority of brachiocephalic syndrome dogs that we see before 4 years of age, we can prevent them from becoming critical as they age. We can never make them perfect, but we can prevent them from being critical. If we see them at 1 year of age, we can actually pretty much guarantee that their quality of life is going to be much improved, as is their lifespan. So early and aggressive surgery for brachiocephalics is my motto. I'm a surgeon. they don't get early intervention? What if they go their whole life and get fat, have luxating patellas, osteoarthritis, no one ever does surgery, they have a little glaucoma, and they present to you at 8 years of age like this pug? He probably goes to Mike before he comes to me. He's in respiratory distress. He's had a long weekend. It's been hot. His owners have wanted to do outdoor activities, which he can't tolerate. He's coughing. He's gagging. He's open-mouth breathing. He's vomiting occasionally. He's vomiting every time he drinks water. He seems like he's coughing, so he's probably going to be a candidate for Kerrie to have a look at his lower airway and see what kind of disaster he's aspirated into there. He snores all the time, not just when he's sleeping. He snores all the time. And often these guys are presented on emergency as they age because they just have no ability to compensate for heat or stress or high altitude or anything. This dog has a brachiocephalic end stage. He's in laryngeal collapse. Never a good thing when the corniculate process of the epiglottis fold over each other like a deck of cards, like fold the doors were done. Not good. You can look up and over the epiglottis on the left on the real-time picture, and you can see those two little things sticking out right there. Those are not his lateral ventricles. That's actually the corniculate process folding in on itself because he's collapsing his airway. So when they're born, why don't they collapse when they're born if this is a defect? Owners ask me that all the time. Well, he was fine yesterday. Well, yesterday was the day before he developed chondromalacia, where his cartilage can no longer sustain any kind of tone and hydration when it's being bombarded with turbulence. So turbulence is just a word. Most clients, when I talk to them about turbulence, I talk about an open window and curtains. The curtains flapping in the open window is not a good idea. In these dogs, we need a nice clean exit out the window. We need the curtains tied to the side, and we need them to not be moving for this dog's whole 8 years of his life. So this dog has the trifecta. He's got the stenotic nares, his soft palate's way too long. He has everted laryngeal sac gills, which has given him almost no room to breathe in the ventral airway. He has laryngeal chondromalacia and collapse, which has given him no ability to compensate or move his arytenoids dorsally, and he's got some degree of tracheal hypoplasia, which we see in the brachiocephalic breeds. Okay, I'm going to apologize for this. Everybody get ready to spin in your seats. The first part of this video was upside down, and I tried to clip it, but no go. So close your eyes until we get to the part where we reintroduce the scope right side up. Otherwise, you'll be sick. Okay, here we go. So if you'll notice, hopefully Cindy can give me some help here. Dorsally is his soft palate. His soft palate is moving, and it's buttoned down where it's supposed to be, and he's trying to move air through his nasal pharynx because that's where he's supposed to move air. But his soft palate is so edematous that you can barely find his airway. So these are the ones that people call me and go, what the hell am I supposed to do with this? And the question is, this should have been probably handled years ago, but you can see by the manipulation with the Alice tissue forceps of that soft palate that he has pharyngeal collapse. His entire pharynx falls in as he tries to suck air, and he's been doing that for 8 years. So he not only has a redundant soft palate, he has tonsillar enlargement, and he has a folded epiglottis, and in about a half a second you get a little view of a collapsed airway. After we let the soft palate go, you're going to see what his struggle is when he tries to breathe. Exhaling doesn't seem to be much of a problem for him. He can find a hole to get the air out. It's inhaling. He can get the air out, but when he inhales, he just pulls that soft palate right back into his airway and creates an obstruction. And the next time he breathes, he everts his saccules and just traumatizes his entire airway till he's developed laryngeal collapse. Can we resect the soft palate? Yes. Can we clear up the ventral airway by removing the saccules? Yes. Is that going to be enough? Probably not. He's probably going to need to have some effort made to remove the tonsils, just to give him a little room. He's going to need probably a lower airway evaluation to figure out if he has respiratory lower airway disease and pneumonia. And in addition, the owners need to be counseled that his airway could use a little temporary or possibly permanent bypass relief. Just stop the turbulence, stop the madness, and start with a tracheostomy. So for us, a tracheostomy gives this dog a whole new life because he no longer has to have all that trauma to his upper airway, all that swelling and edema can go down, the resected soft palate can heal, the ventricles can heal. And is he a permanent tracheostomy? Possibly. He might be a temporary tracheostomy until the edema and swelling goes down, and then he can go back to being 30% capable in his airway as opposed to only 5% capable like when he walked in. Permanent tracheostomy is not for everyone. That's a in-depth conversation that you need to have with your owners about what animals can and can't do. I've had big dogs with permanent tracheostomies that the owner forgot he had that because he lives in the backyard. And 3 years later, she said, I think it's still open. And it was. Never cleaned it, never treated it, let him swim, forgot he had that. I've also had dogs like this that you thought you might be able to help them, but the external chassis of this dog is so full of folds that the chance of this staying open is pretty slim, in my opinion. If this were my dog, I would probably have resected a lot more skin and done a lot more, is Dr. Wilson here? A lot more dermatology work on this dog before I would have given him a license for a permanent tracheostomy. Next one, you can hear him coming. This is the Cujo part of the talk. 7-year-old St. Bernard, I think we have a diagnosis up here. This is a 7-year-old St. Bernard that has exercise intolerance, and he comes to see me because he's lame. So for me, the exercise intolerance is pretty obvious. This dog can barely move air, and he's like, okay, I'm done now. That's all I can do. This is it. So for these guys, even though they're not brachiocephalic, they are still compromised. This dog's probably only using about 40% of his airway, and all of that at turbulence. So these guys are often plagued with more than one disease. They go to the medicine department and they get diagnosed with myopathies and with Addison's disease and with, they have a variety of diseases that cause generalized weakness, and sometimes it's neurologic, sometimes it's systemic. So for us, this dog's a candidate for a laryngeal exam. We need to take into account a pretty strenuous workup on his lower airway and on his body in general to be sure that he's a good candidate for his laryngeal exam. In the larynx, there's a lot of moving parts, and they move and you move and the dog moves, and it can be difficult to make a call. Even if you're the surgeon that's going to be repairing it, it can be a difficult call to say, yes, this one doesn't work. So on the left is a diagram of what happens when you swallow your food. If you're a dog, you close your airway. That requires just as much strength, control, and innervation of your nerves as does the one on the right, which is the real-time picture, which shows a dog that's fully abducted, abducted, where both the left and right arytenoid are abducted. They're taken away from the airway, and he now has a huge hole that he can breathe in. The one on the left is adduction. That's a muscular control is required to shut your glottis so that you don't aspirate your food, your water, or drown while you're swimming. Laryngeal function on the left and right, two extremes. What do we get when we have a laryngeal paralysis? We get blah. We get nothing. We get paramedian. We get almost closed, almost open. One side's maybe moving or fluttering. For these dogs, they are coming to see you because, that dog came because he was lame, but a variety of them come because they're in respiratory distress and they need medical stabilization. They might have pulmonary edema. They may need some kind of treatment to get them stable. For us, we talk to owners about surgery, and they say, what can we do instead? Can't we just keep him indoors in the air conditioning and never travel? Well, yeah. He can't go to the high altitude. He can't have a temperature over 70, 60, probably 65 degrees he would like. For management at home, I have owners that buy floor fans and set them on the floor all the time in the summertime, and the dogs will go sit in front of the fan because they can move enough air to cool themselves down without any kind of exertion. These dogs are sometimes oxygen dependent, especially if they've aspirated or have secondary complications. For us, glucocorticoids sometimes helps, sedation always helps, and antibiotics is often indicated in either surgical or just diagnosis and medical treatment or management. If surgery is going to be the answer, we do arytenoid lateralizations, which means we are going to yank that arytenoid up and out. The two ways to increase the glottic diameter, if Cindy gives me a hand on the diameter of the glottis, you can see the right and left arytenoid, the epiglottis, the soft palate clearly well out of our way. And in this case, the left arytenoid is pulled back into a lifted position, and from the positioning, this has obviously been a cricoarytenoid suture. I use nylon suture, number 1 or number 2, and I have 2 sutures for each side. I have done them bilateral and unilateral. For a right-handed surgeon, unilateral on the left is my preference. Because these dogs have neuromuscular weakness and disease, resecting the soft palate is something that we have taken to lately just because it seems to give them some relief. If you look at them in general, they're big dogs, labs, hunting dogs, and they have neuromuscular weakness in general. It would stand to reason that whatever disease has caused their laryngeal fatigue or their innervation or their myopathy is also causing a myopathy and a weakness in their soft palate. So when we do the lateralization procedure, we will often evaluate the soft palate for resection. Postoperatively, arytenoid lateralizations can't swim. If they have bilateral lateralization, they're pretty happy campers. They can go on to live a pretty normal life, including, yes, exercise, heat tolerance. The owners often come back in and say, why did I not do this 5 years ago when I first heard the noise? Well, it's not without risk, it just has a low risk, and when it works great. A lot of the dogs are hypothyroid and need some other support. They need their regular veterinarian to follow up with their quality of life issues like obesity and hypothyroidism and appropriate exercise for old dogs and treatment for their osteoarthritis so they can enjoy being more active now that their airway works. The biggest thing that we see in these guys is aspiration pneumonia. We just recently had a case that had tieback, a lab that had tieback surgery a couple of years prior, and he was staying with some friends, and he decided that he was going to wolf a mango seed from the floor and create a foreign body in his stomach, and they induced vomiting to remove the foreign body, and he aspirated from the induced vomiting, the sedation and induced vomiting. So the biggest risk and the biggest detriment to these guys is aspiration pneumonia, which can occur days, weeks, and months later. A small amount of aspiration pneumonia can be tolerated and can be treated. If they have a catastrophic aspiration pneumonia, like swimming in the ocean, usually they succumb to that or they end up being a prolonged guest at Mike's. For us, when we send these dogs home, I've heard feed them up, feed them down, feed them elevated, feed them on the ground. Make sure you give them a slurry, give them water. For us, if you can make a food bolus for these dogs so that they don't have to mess around with anything sloppy in their mouth, and it's the perfect size bolus to go down the hatch, a meatball bolus from the ground, for me, is the best. Because when your head's on the ground, if you are going to aspirate, at least gravity will pull it out your nose instead of having it go down your airway and into your larynx. So most of these dogs, we feed them on the ground, and we feed them boluses for the first 3 to 5 days after surgery, and then the majority of them are back to wanting their dry food. I think the next video is a video that was compiled for looking at the mechanics of a laryngeal paralysis. And what happens in the laryngeal paralysis is that the airway and the arytenoids actually paradoxically get sucked in and become part of the problem. The middle part of the video is slow motion, and then the end part of the video is the actual laryngeal tieback dynamics. So you can see what the dynamics look like in laryngeal tieback. So if Cindy could point this stuff out, I'd be so grateful. Again, the Cujo sound. And you can see the ventral part of the larynx is actually being sucked into the airway. He's moving. He's awake enough to be wanting air, but neither the right or the left arytenoid move. And here's the slow motion. Dr. Sebastian did this video for me, so kudos to him. And here's the tie back. Much better. So in this dog, again, left arytenoid is tied back. The soft palate is a little bit long, probably be resected after this. The big old blade on the ventral surface is your intervention into this dog's life. Again, we distort them. In the view, in this video, dorsally, I have thank you, tongue depressor. I said a stick, tongue depressor, and ventrally it looks like a laryngoscope, which again, you've distorted the entire environment. So when you look in there, it's like, wow, what's really going on? Do I have a hold of his epiglottis? No, we're not actually holding it. We're trying to just get a look in there. So without the sound, it's probably not as dramatic, but clearly he does have paradoxical movement on the right, but not really enough to pull into the airway now. Now he's half right. He still has a right-sided collapse, but his left side being wide open allows him no airway sounds. Questions? Oh, this is actually a dog that has a primary nasal septal defect. He has a right nose and a left nose, but they haven't been introduced. He also actually looks like he has a right and a left upper mandible and dentition that's not been introduced, not directed in the same direction. So the plastic surgery we did on him was just to connect the dots. Any questions?